Okay, well, why don't maybe we can get started. So it's my pleasure to introduce Dr. Nan Wang from Stanford University as our speaker for today. Dr. Wang did her Ph.D. with the Bialy at UCLA, doing multitasking DCE MRI, and is currently doing her postdoctoral fellowship with Dr. Kawan Tetsenpop at Stanford University, doing sort of really amazing, very fast push button MRI using sort of a variation of EPTI, which is a method recently developed from the group at MGH. So really looking forward to hearing the latest advances from her research and also congratulate her on a recent award of K99R00 award. So she's on track for an independent career and looking forward to following her research for many years to come. So thank you again. And if you have questions for Dr. Wang during the talk, feel free to post in the chat or raise your hand, and then we'll also have plenty of time for questions afterwards. We've asked her to give a fairly technical talk, so be as technical as you want in your questions. Okay. The floor is yours. Thank you again for giving us a talk.
Thank you so much for the introduction, Tom. And it's a great honor for me to present my work here about towards push-button MRI, fast, quantitative, and motion-resolved techniques in body and brain. And yeah, feel free to stop me anytime if you have questions, and also I'm happy to discuss after the talk. And this is a very brief self-introduction, as Dr. Liu just introduced. I did my PhD at UCLA with Dr. Bialy, and my main focus on that time is motion-resolved quantitative body imaging. Then kind of try to broaden my experience. I joined Stanford in year 2021 and started a new journey in neuroimaging. And my main focus currently is like developing this ultra-fast neuroimaging technique, which is quite a big transition, but in the meantime also share lots of similarities and same technical advances. Today in my talk, I'll briefly start with the concept of the push-button MRI, then move on to some highlights of my work in the motion-resolved quantitative body imaging, mainly the multitasking DCE technique, then followed by the work in advanced neuroimaging, mainly the spherical EPTI, and conclude by the outlook into the future. MRI, we all know, is very safe imaging modality. It has no radiation or ionizing. So basically, people can receive as many times as you want, but the hard part is making the appointment. MRI has exquisite soft tissue contrast, including the basic relaxation parameters like T1, T2, T2 star, all the way to the fine structure like the iron, myelin, concentration, fat fraction, and all other stuff, and can be all the way to the fancy function parameters like the perfusion, metabolism, activation, and extra. However, although MRI has such power to do all this quantification, but it's very hard to do them actually in the reality. That's because the fundamental challenge for MRI it's slow speed. And because MRI is slow, so it's very subjective to the changes or contamination in the signal, such as from all kinds of motion, physiological motion, block motion, from the drifting and fluctuation of the main magnetic field, and from some of the interaction between the system and hardware, like the eddy current. And another nature for MRI is that instead of directly acquiring the parameters, it actually only acquires a parameter-weighted image. So the thing is that those weightings can be easily affected by a lot of confounding factors, such as the sequence parameter setup, the coil placement, the reader interpretation, and lots of other stuff. And all of these challenges limited the accessibility, fidelity, and reproducibility of MRI. Luckily, over the decades, our human intelligence have developed a lot of different advances from the sampling, reconstruction, and analysis aspects to make MRI much faster in acquisition, richer in the information, including different sequence structures with multi-parametric encoding, and a lot of efficient sampling pattern, including random undersampling or non-Cartesian sampling. And on the reconstruction side, a lot of advanced reconstruction models have been developed, including the exploit of the transfer domain sparsity as well as redundancy in the spatial temporal dimension to allow for higher undersampling with improved image quality. So taking all the advances part together, now from just imaging a static image, we can easily take a video during the contrast changes of MRI. And that allows us to do quantitative imaging or spatial temporal imaging. And we can even capture the information that has been considered as confounder factor in the past, but now we can actually quantify all of them and get richer information for clinical and scientific purpose. And this brings the concept of push-button MRI, where MRI can be easy to set up. For example, there's no tedious threshold required. It will be rapid with high resolution acquisition and can provide rich information for diagnosis and disease management. And it will be continuous acquisition without with without all the motion and field imperfections and getting us all the information we want. This is definitely a very ambitious long-term goal, and hope my work is contribute a little bit in such direction. And talking about this, I'll start with some introduction of a highlight of my work in the motion-resolved quantitative body imaging, the multitasking DCE technique. DCE stands for Dynamic Contrast Enhanced MRI. It has been a key protocol in the clinical diagnosis and management of a lot of diseases such as cancer, atherosclerosis, inflammation, and etc. So how DCE performs, it usually involves the injection of the contrast agent concentration and the T1 weighted imaging acquisition before, during, and after the contrast injection. And the contrast agent distribution will change the contrast of the certain tissue, and such change in contrast will reflect the macrovascular properties of the tissue. And because macrovascular properties such as the macrovascular density, permeability, changes at all kinds of physiological and pathological processes. So this information can be used to diagnose and manage the diseases. And what's more important is that usually the changes in the macrovascular properties precede the actual disease morphology. So if unleashed is fully powered, DCE-MRI has a potential for early diagnosis. Here's a typical process of how DCE-MRI is performed. The image, your T1 weighted image is acquired before, during, and after the contrast agent injection. And the tissue signal can be extracted for different voxels, including the blood, all kinds of tissues, and you will see a contrast enhancement curve. Usually, for abnormal tissue, it will have a dense vasculature and a higher permeability, so it will tend to have a sharper peak and quick washout. And for normal tissue, it probably have a plateau or persistent enhancement during the time course. Analysis of DCE-MRI is also quite a lot. The basic way is to do qualitative analysis, which people categorize the shape of the curves into different types, like the sharp enhancement, sharp washout, or plateau, or persistent. And for example, if we can do fine time resolution capturing of the curves, we can also do quantitative analysis, means we can use a mathematical model to actually estimate the macrovascular properties like the density and the permeability out of those curves. One thing you can easily imagine as a challenge for DCE-MRI is that it's always really hard to acquire big coverage, high spatial resolution, and high temporal resolution at the same time. So compromises usually have to be made that will lead to the insufficiency of the information for DCE-MRI. Also, we apply this technique especially to the abdomen. Motion can be a big challenge. The motion can be the physiological motion or the bulk motion, and all kinds of motion will lead to the reduction in the image quality as well as the long-term scan time due to the requirement of the breath hold or repeat of the scan. The third thing is it's actually more subtle. It's because the contrast agent concentration changes proportional to the changes in the relaxation rate, the reciprocal of T1. However, perform dynamic T1 mapping is actually really, really challenging. So people only acquire T1 weighted signals. And when contrast agent concentration is low, the change in the T1 weighted signal is actually can mimic the change in the relaxation rate. However, when contrast agent concentration is high, there's large error. And such error is okay when you only use qualitative analysis. But when you're trying to move to quantitative analysis for disease tissue where the contrast agent is usually much higher, that can actually lead to much more errors. And also over the past years, there has been report that the gadolinium may actually deposit in different body parts. Although no clear clinical results have been showing from such deposition, people still have concern, and that highly limited the use of DC MRI in the screening of a high-risk population and such related applications. So how can we make DC MRI better to really unleash its power and to really get richer information from it? So let's first imagine what type of image we want to get from DC MRI. We definitely want 3D coverage of the whole anatomy we're interested in. If there's motion, we probably want to capture all the different motion states. And during the contrast agent injection, we probably want to capture all the fun DCE phases along the time course. And if we want to do dynamic T1 mapping, we probably want to include more T1 contrast changing information at different DCE phases. And this makes a multidimensional image tensor. And directly imaging this multidimensional image tensor can be really challenging because you can imagine each single dynamic temporal time point will require acquisition of a 3D volume, which itself can be a few seconds to a few minutes. And the acquisition time will increase exponentially to the number of dimensions you want to acquire. And second is a very realistic challenge is when you're actually doing the acquisition, it's really hard to identify which case space belongs to which motion states, which physiological motion states. And that can be a secondary challenge. So how can we resolve all these challenges and really get this multidimensional image with rich information back from DC MRI? One solution is the MR multitasking framework, which was developed to resolve this multidimensional image. So multitasking framework utilizes a Lorentz tensor model. It forms the image as a tensor. And because, as you can imagine, there's a high correlation along and across different dynamics, you can actually exploit those correlation along the multidimensional, which means this high dimensional tensor can be factorized into the product of different factor matrices representing the spatial variation, respiratory variation, DCE variation, or like the T1 variation, and so on. And by factorizing this whole tensor into those smaller factor matrices, they are much smaller in size. And the degrees of freedom needed is only increases linearly with the number of dimensions we want, not exponentially anymore. And second, especially important for DCE MR is that those separation of the images into smaller factor matrices implicitly separate the temporal matrices and the spatial matrices, which means, for example, we can determine those temporal matrices first from a subset of the data containing high temporal resolution, low spatial resolution. And then we can recover the spatial matrices by fitting the temporal matrices into the high spatial resolution K-space spread out at different K-space location. This decouples the trade-off between the spatial and temporal resolution, and which means we can achieve a big coverage, high spatial, and high temporal resolution in the same time. So let's go into more details how we can really achieve this. From the sequence structure, so what information we want to get from the sequence? We want to get the dynamic T1 information. That's why we use this saturation recovery preparation pulse periodically to generate the T1 information. And we do continuous acquisition with flash readout to capture the whole DCE time course. And in acquisition, the center K-space line is acquired frequently, probably every 80 to 100 milliseconds. This forms this subset of the training data to determine all the temporal factor matrices. And the rest of the data is acquired randomly from the high resolution K-space data, which is used to determine the spatial factor matrices. And one thing to note is that the saturation recovery period is usually 50, 100 milliseconds to 1 second. And that can be our temporal resolution for the DC images, which means we can get one dynamic T1 mapping every second. After getting the data, how do we really build reconstruction this high-dimensional image? The first step is straightforward. It uses low-rank tensor subset model by separate this image into a spatial coefficients and a single-dimension temporal coefficients. This single-dimensional temporal coefficients will be a mix of the contrast of the motion, the DCE, and the T1 recovery. This is a refracted image of the mixed contrast. And this single-dimensional mixed contrast image is used for the identification of the respiratory motion. The way to identify respiratory motion is we place a ROI on top of the liver dome, and we extract the liver dome position by performing some thresholding over the signal. And after getting the liver dome position, we divided each case-based line into a certain motion bins. We usually use 6 motion bins. And the third step is a really fun part. Now we already know each case-based line belongs to which motion states, which DC state, which actually just following the elapsed time, and which T1 recovery curve, which is naturally decided by the sequence. We can assign our sequentially acquired case space into the tensor that containing all the respiratory states, all the DCE states, all the T1 recovery states. And for the simplification of the demonstration, we just ignore the T1 recovery states for now. So the sequentially acquired data into the tensor is very sparsely sampled, but don't forget the high correlation along and across all the dimensions. And those high correlation give us the power to recover all the information back. And mathematically, we are using the low-rank needs as well as temporal total variation to recover all the missing time points back to the tensor. And now you have like all the information in the temporal tensor for all respiratory motions, all DCE motion, all DCE contrast changes, and you can perform a high-order singular value decomposition and extracting the respiratory factor matrices, DC factor matrices, and T1 recovery factor matrices. And in the last step, we fitted all the temporal factor matrices into the randomly acquired case-based data to get our spatial matrices back. The production of all the factor matrices will give us back the image tensor. And now with this recovered image tensor, you can actually freeze or display any dynamics you want. For example, we can freeze the respiratory motion states and only display all the DCE time courses, and we see beautiful DC images at high temporal resolution with no contamination of the respiratory motion. So for multitasking DC, what it has been achieved is it can do three-dimensional high abdominal coverage, can be as large as the entire abdomen with a sufficient spatial resolution. It has multiple temporal dynamics, including motion states to resolve the physiological motion, DCE time course to achieving 1 second temporal resolution, 1 second per DCE phase, and saturation recovery times to allow for dynamic T1 mapping along the DCE time course. It is a true multidimensional motion resolved quantitative DCE technique that can be potentially used for lots of different clinical and scientific purposes. One highlight application of multitasking DCE is the application on the study of pancreatic cancer. Pancreatic cancer is a very deadly disease. It's overall the 3rd leading cause of cancer-related deaths, with a poor 5-year survival rate at only 8%. And the most curable way for pancreatic cancer is early diagnosis or early monitoring of the treatment response. DC is always very important for the diagnosis and management of pancreatic cancer, but it is very challenging because the respiratory motion, patients have to hold their breath. So the acquisition of the coverage is first very limited, and second, because the patient have to take a break and then re-hold their breath during each phase. The temporal resolution is also very poor. The time break between each phases can be like 30 seconds or even longer, depending on how good the patient can hold their breath. So what we can do with multitasking DCE? For the pancreas study, we can do the whole abdominal coverage with a matched spatial resolution at 1.2 millimeter in plane and 6 millimeters through plane. And we can do true free breathing acquisition and dynamic T1 mapping every 1 second for high temporal resolution DCE information. Here's a representative multidimensional images from multitasking DC. We can freeze all the temporal dynamics and only look at the 3D volume. We can look at the saturation recovery curve only for dynamic T1 mapping. We can look at the respiratory motion only, and we can freeze the respiratory motion and look at only the DCE time course. Take a closer look of the signal curve. We can see each pixel, the signal curve of each pixel at each motion state contains consistent of the saturation recovery curves. And those each saturation recovery curves will give us the ability to do one T1 mapping, and we can have a very fine curve at every 1 second point for dynamic T1 mapping. And the dynamic T1 mapping will give us the power to achieve the true quantification of the contrast agent concentration at high time resolution. And this will further give us the power to do the modeling of the macrovascular properties, including the macrovascular density, permeability, and extracellular space, which is mainly correlated with the amount of fibrosis. This is an example from a healthy volunteer with normal pancreas. And you can compare that with example from true pancreatic cancer patient, and the tumor is labeled by the yellow dashed lines. First, you can see the high time resolution multitasking DCE really capture a fine delineation of the contrast agent dynamics in the curve. And we can still estimate the macrovascular density, permeability, and fibrosis. And one thing to note is that for pancreatic cancer, it's actually very different than most of the cancers. It's actually hypovascular with a low vascular density and high fibrosis, which you can see the result from multitasking DCE matches very well with the pathology of pancreatic cancer. And this shows a big difference between the tumoral and non-tumoral area. And by performing some statistical analysis of the macrovascular property among the normal pancreas, the tumor in patients, and the non-tumoral in patients, we can see the density, permeability, and fibrosis can show a big differences between the three categories, which indicate it can be further used for the differentiation of the diseases and probably in the future for the staging and treatment monitoring of the diseases. Another highlight application of DCE, multitasking DCE is on breast cancer. So unlike pancreatic cancer, breast cancer is actually considered as a sort of curable, especially if that was identified at the early stage. And for breast cancer, those high-risk population usually received an annual health screen. But for health screening, MRI is not considered as a routine. First is because MRI is really expensive and slow, and second, because people still have the concern for the degradation of the contrast agent. And with conventional technique, DCE MRI on breast, because of the requirement of the big coverage and the high spatial resolution, they can probably only do 30 seconds to 1 minute per DCE phase, and that kind of filtered out a lot of the very important information. So with multitasking DCE, what we can achieve is the whole breast coverage at 1 millimeter resolution and dynamic T1 mapping at every 1.4 seconds. And what's more is that we can achieve only 20% dose, which can be potentially good for the screening and long-term follow-up. And the reason we target for 20% dose is because we can do dynamic T1 mapping. So we have a better contrast between the tissue, between the diseased and non-diseased tissue. And this work was elected as a finalist of the Young Investigator Award in the year 2021. Here's a comparison of the conventional DCE with full dose and multitasking DCE with only 20% dose. We can see first from the image quality at the peak enhancement phase, multitasking DCE with only 20% dose actually showed pretty good image quality. And in terms of the temporal dynamics, multitasking DCE can capture much finer temporal delineation of the tissue. And it can proceed to estimate the macrovascular properties, including the blood flow, the macrovascular density, permeability, and fibrosis. The first example is from a healthy subject with no breast cancer. And second example is from a patient with a benign tumor, where you can see the flow, density, permeability, and fibrosis is very different from the healthy breast. And for malignant tumor, you can further see the differences. It has increased the flow, increased the vasculature density, permeability, and pretty low fibrosis. And that also agree with the histology of the breast cancer. And we recruited 7 patients with triple negative breast cancer in total and sent all the images for the review of the radiologist. We can see first multitasking DCE and conventional DCE. Multitasking DCE with only 20% dose. It's agreed very well with the conventional DCE results in terms of the curve type category. And it provides at least equivalent or even better image quality with only 20% dose, which means multitasking DCE can at least give equivalent clinical diagnosis power, and it has the potential to give even richer information about the macrovascular properties. So at the conclusion for multitasking DCE, it enables motion-resolved continuous acquisition with the ability to achieve big coverage, high spatial, and high temperature resolution imaging with dynamic T1 quantification. And the results from multitasking DCE in lots of applications have been shown to consistent with the conventional techniques, and it can potentially enable the characterization of the macrovascular properties and can potentially increase the early diagnosis and treatment monitoring. And there's a lot of ongoing projects in my PhD group, including validation of the macrovascular properties estimated from multitasking DCE against the histology. This was conducted on the small animal study. And also using this low-dose multitasking DCE for challenging organs like the moving organs such as the liver. And the idea of multitasking DC actually can be applied for lots of different techniques with improved image quality. For example, we have already done the motion-resolved multiparametric mapping for the abdomen, including T1 and water-specific T1, T2 star, and protein fat fraction for the whole liver with free breathing acquisition in a short scan. And it can potentially be used for the study combination with a spiral or other UTE sequence fracture for lung imaging, or it can be used for distortion motion without body imaging, which is also ongoing project. Talking enough about the body imaging, a second very exciting work is about the advanced neuroimaging. Body imaging and neuroimaging, they're facing like the challenges at quite different level, but in terms of the techniques, they actually share lots of the similarities and which can benefit both body part. And the highlight work in the neuroimaging is the development of this spherical echoplanar time-resolved imaging. The origin of this work is from this very popular echoplanar imaging, which has been largely used, especially for neuroimaging. Because echoplanar imaging is a very, very efficient sampling technique. Compared to the regular gradient, like the GRE with a flash readout, which you'll start from the center for each readout, then come back to the center and waste a lot of time on the spoiler for each readout. EPI actually usually sampling the case space, the entire case space, all the readouts in one round with this polarity switching readout gradient. It is very efficient, but also in the same time, it occurs each readout at different echo time as shown here. If the cases stay stable, then that can be perfect. However, the cases is definitely not stable at all. There will be like the B0, the mean field inhomogeneity induced phase over time, and there will be T2 star decay. And the B0 induced phase and the T2 star decay will actually inducing distortion and blurring on the image. Although EPI always facing these challenges, it still has been largely used for lots of neuroimaging applications, mainly because it's like super fast. For example, EPI is like the default sequence, the sampling structure for functional MRI, where it can capture like very high temperature resolution functional activity of the brain. It has been used for like the T2, T2 star mappings at multiple echo times, the susceptibility imaging, as well as diffusion imaging, given its really fast speed. So the question we want to answer and here is that, can we keep the efficiency of EPI, but in the meantime, solve its challenges? There's a lot of methods, and one powerful solution we proposed here by the group previously is echo-planar time-resolved imaging. So let's take a look at the API acquisition from the KT space. It actually acquires different echo time at different readout at different echo time, and then combine all of them into one single image. So what EPTI trying to do here is that it uses a few shot to sparsely sample the cavity space. But instead of combining all the readout into one single image, it actually tried to recover all the missing point in this cavity space and get the images at different echo times back. So EPTI actually resolves the T2 star decay and the Bieder-induced phase along the echo time, and each single image at different echo time is a distortion-free and blurry-free image. So how EPTI recover all those missing points in the KT space to get the entire KT image back? It also uses this low-rank subspace imaging model, which is very similar to what we introduced in the multitasking DCE work. So you can see there's a high correlation along the images across all the different echo times. That means this KT image matrix can be decomposed into the product of the Bieder-induced phase over time. Temporal subspaces representing mainly the T2 star decay, and the spatial matrices representing mainly the spatial weighting. And now the temporal subspaces can be generated from a dictionary containing mostly the T2 star decay. So the only unknown variable to resolve is the spatial coefficients, which is much smaller in size compared to all the echo times at the beginning. And that gives us the reduction of the degrees of freedom, as well as more room to do undersampling and shorter scan. EPTI has been applied for the application of a lot of different quantitative neuroimaging, starting from its intrinsic power to quantify the T2 and T2 star, and has been used with different sequence structure to quantify T1, proton density, money water with a variable flip angle, or diffusion with a diffusion preparation. If we take a closer look at currently, in terms of sampling, what EPTI has been achieving previously by the group, they can do, for example, combined with either gradient echo sequence structure, EPTI can do whole brain coverage, 1 millimeter isotropic resolution with only 65 seconds to achieving multi-echo imaging with the power to do T2 star mapping, proton density, and Q estimate quantification in only 65 seconds with undersampling rate as large as 248. However, if I take a closer look of the image quality, you can see at the lower brain, because of the coil variation, is still quite challenging in terms of the SNR. And there's still some like the residual streaking and shading artifacts. So the question we want to answer here is that, can we do even further acceleration, even higher resolution, and even better image quality altogether? And the answer is yes. Given all the technical advances I'm going to introduce in the following, what we can achieve now is that we can achieve the same whole brain coverage at 1 millimeter resolution with only 45 seconds, and 0.75 millimeter resolution at 90 seconds, with improvement in the image quality, the SNR, and reduction in the artifacts with very nice homogeneous image quality. And one thing to note is that all the resolution, including the sub-millimeter resolution at 90 seconds, is achievable on 3T clinical field strength, which indicate a direct clinical translation of the techniques. So how did we do this? There's the highlight of the method we do. In terms of the sampling, we developed this spherical sampling, which can achieve further acceleration as well as increase the incoherence for better image quality. We improve our Bieder estimation methods as well as eddy current correction methods to give us better image quality. And we also utilize this neural network to boost the SNR for sub-millimeter resolution imaging. Start with sampling. How do we do that? Here, start with the most familiar 2D EPTI sampling pattern, where it covers the cavity space into a few shots. And to do 3D, you can probably directly extend this 2D sampling by acquiring over the partitions. But this is not optimal because for 3D, you can optimize your undersampling over both cave and KT direction. So a better way to do this is called block APTR, which has been used for all the pre-study. Is that the undersampling unit is a block, and each shot can covering different K by KD points within this block, and different shot covers the entire K by KD T space. And the number of blocks equals the number of shots, and the undersampling rate equals to the block size. So how do we further improve this sampling strategy? We developed this spherical sampling. It's still a block-based sampling strategy, but kind of employ the spherical envelope on top of that. At the center, the block is exactly the same as the previous block sampling. And when moving towards the outer K space, first we cut off some of the K space corner to reduce the number of shots. Second, when moving to the outer K space, we reduce the length of the readout, which means in the same action length, we can now acquiring more echoes to cover a larger K by KD block. And this also gives us the reduction in the number of shots. So this spherical coverage not only gives us a power to achieve 1.5 times acceleration, but it also gives us like varied echo spacing at different K space location. This significantly improves the incoherence, which means now all the echo and even echo are shuffled because of the varied echo spacing, and that gives us a more robustness towards the odd even phase error. And it's a spherical sampling. It's very flexible, can be used for different matrix size, different coverage, and with higher resolution, there's finer steps to do the spherical approximation, and that will allow for even higher acceleration. And after talking about sampling, so what can we improve from the refraction side to make the image quality even better with a higher acceleration? This is a standard APTI refraction model. We have the acquired data. We have the prior knowledge of the sensitivity map, probably a B0 from the low resolution calibration data, temporal subspaces containing the T2 star decay from dictionary, and the only thing we need to recover here is the spatial coefficients. So from this refraction model, you probably already noticed that how accurate the B0 map is can significantly affect our image quality. Because EPT has long readout, even if your B0 map is off by 5 Hertz, at the later echoes, it probably already 10 to 20 degree phase differences, and that can introduce significant errors in the image quality. So B0 from a low resolution calibration data is always not good enough. Previously, what the group did is that they use the initial B0 get from the low resolution multi-echo calibration data, and they do a database update by using the temporal subspaces containing a delta B0 with about positive to negative 30 Hertz of degrees of freedom. And they recount the spatial coefficients and temporal coefficients with a small amount of additional phase to estimate an additional B0 on top. And the summation of the initial B0 and the additional B0 becomes the updated B0 used for the recount model shown here. So why don't we directly perform the reconstruction in this way with the subspace containing phase? That's because when you're trying to including phase in your subspace, that means you need to increase the number of rungs, and the noise level in your spatial coefficients linearly grows with the number of rungs. So that means like your final results can be noisy. So that's why we separate the B0 update and the final refraction into 2 separate steps. However, although this can already help a lot in the condition of the image, when we move into sub-millimeter resolution, it's still quite challenging. This is a result with our previous recon pipeline. You can see with sub-millimeter acquisition, the noise level is quite high in both the B0 map as well as the actual images and maps, and there's a lot of residual artifacts. So how do we solve this? First, we propose this iterative rank shrinking B0 update. It's quite similar to the previous single-step B0 update, but instead of trying to get this delta B0 in one step, now we iterative these steps for several times. And each time when we get an update of a little bit of delta B0, we will perform a polynomial smoothing to make the updated B0 much smoother. And by looking at this a few times, the updated bit error can be very close to the actual bit error matching the data. And we perform a last step where we reduce the degrees of freedom of the phase in the subspaces. And we try to only update differences mainly in the edge because of the polynomial smoothing. And the final outcome bit error will be the summation from the initial bit error mapped and including all the delta bit error updated in each steps. So this iterative bit error update guarantees a bit error that both smooth in the center and also sharp on the edge, gives us the most feasible information. Other than bit error, there's some other sort of the artifacts, and one of the major sorts is eddy current, or like the odd even phase errors, which is not only for EPTI but also for all the EPI-based technique. So on EPTI, such errors can manifest as those streaking artifacts or shadings on the images as well as the maps. So where's this artifact coming from? It's mainly coming from the eddy current induced the gradient imperfection. This gradient imperfection will warp your case-based sampling and also manifest as a phase error between your odd echoes and even echoes and subsequently those artifacts on the image. So not only for EPTI, but for regular EPI, when you go with a high undersampling, we will also notice some of the artifacts from this odd even phase error. So how do we solve this in our model? To take a closer look, if we directly take the phase error between the odd and even echoes without any correction, we can see the main part is a linear term along the readout that's mainly from the gradient delay. If we correct the gradient delay with a standard way, there's still a high order residual phase. And this high order residual phase can be estimated from the same low resolution calibration, multi-echo calibration data. And after estimate this high order residual phase, we include this phase into our forward model. And now this can resolve the eddy current induced artifacts in our image. So let's take a look at how these steps can improve our image quality. This is the same slide showing the result image from the previous recon pipeline where it's noisy and has artifacts. And by incorporating our iterative round streaking bit error update as well as eddy current correction, the image becomes much higher in SNR, better in the structure delineation, and much more homogeneous without artifacts. If we flip in between, you can see quite a lot of improvement in the image quality. And specifically for the eddy current effect, this is a example that's showing very strong eddy current artifacts. And after incorporating this eddy current correction technique, you can see the image becomes much better, much homogeneous. And this is a technique that's not only applicable for EPTI, but can also be applied for EPI and all the relative techniques. And although we have the advances in the bit error update as well as the eddy current correction, for sub-millimeter resolution images, the SNR is still not the best. If we perform, like, for example, 2 averages, the image can become much better, but we definitely hope to even reduce the time for any potential average. So what we do here is that we leverage the physics-informed neural network to boost the SNR in our case. The neural network is more like performing an additional regularization onto the image to improve its SNR. And this deep learning model was trained in a supervised manner. So how we build this, our input is our single average sub-millimeter spherical EPTI data. And our ground truth is instead of a free sample data, we actually acquire 6 to 8 average of the spherical EPTI data. The reason is because free sample data at such resolution, such coverage actually will take about 10 to 15 minutes to acquire. And there can be a lot of motion field fluctuation that can affect the image quality. So after choosing the ground truth as the average of the data, we train a model that including the data consistency and the regularization term from the ResNet. And the loss is made between the output image against the ground truth. And for the data preparation, we first, from the 6 to 8 averages of the spherical APTI data, we choose one average as the input, and then we perform the motion registration and phase correction of all the other repetitions to the truth repetition. And we average all the repetitions to perform as the ground truth. And for data acquisition, the network training was all performed on 10 subjects, and each subject will have this 1 millimeter data, which including 120 slices good for training, and 0.75 millimeter data, which will include 160 slices good for training. And among the 10 subjects, we use 7 for training, which including about 2,000 slices in total, and 1 for validation, 2 for testing. And here's the results after including the unrolled network. This is the ground truth image with the 8 average. You can see it has a very favorable image quality with a fine delineation of the brain structure. And for a single average spherical APTI data at such high resolution without any regularization, you can see its image is quite noisy because it's probably a highly ill-posed. If we utilize like the conventional regularization, like the optimized wavelet optimization, it helps quite a lot in the image quality, but still has some like the residual noise. And if we leverage the unrolled network, you can see the SNR is highly improved and the sharpness of the brain structure is still kept. And of course, the unrolled network produces the highest similarity as well as the lowest error. So taking all these advances from sampling, reconstruction, and the leveraging of the deep learning together, we perform our spherical APT studies at 1 millimeter resolution and 0.75 millimeter resolution on 15 volunteers and 2 pediatric patients, who have like very different T2 star and QSM values compared to the adult population, which is a good test of our generalizability of this entire pipeline. Here's our final results. We can see spherical APTI can achieve whole brain 1 millimeter multi-echo imaging and T2 star QSM mapping in only 45 seconds. And this is an image of the multi-echo image, T2 star, Ph.D, and QSM from different brain orientations, shows a very nice image quality. And for the same coverage, we can achieve 0.75 millimeter resolution with only 90 seconds. And same thing, like we can look at the image from all the different echo times, the T2 star and QSM with a very preferable image quality. If in the same volunteer, we compare their 1 millimeter data and 0.75 millimeter data, we can see the 1 millimeter data is already pretty nice, showing the very fine brain structure. But the 0.75 can always show like even finer brain structure at those like the very subtle area, which means like higher resolution is always preferable. And the test on our pediatric cases have shown that even on the smaller head with very different T2 star and QSM values, there's an entire spherical APTI pipeline leveraged with unrolled network can show good delineation, high SNR, and fine brain structure preservation on the pediatric patient. So at the conclusion of the development of this spherical APTI technique, we can see it achieved additional 1.5 acceleration compared to the already very fast APTI technique. It can produce a high quality image and also much more robust to the eddy current induced errors as well as the B0 challenges. And what's more important is that all these like different advances, including the sampling, the eddy current correction, the B0 update, it's not like very limited to APTI. The idea actually can be used for lots of similar techniques, including API and other techniques. And this entire pipeline is quite generalizable and can be used for different patient cohort. And I know I'm already running out of time, but I just want to quickly show an ongoing work that kind of conclude my technical presentation. And this is also very important to make APTI more robust to like the bulk motion and the B0 fluctuation. So bulk motion, we already know it's a big challenge for neuroimaging, and it's has caused a lot of the repeatability or reduction in the image quality, and this is really unwanted. And behavioral variation is something more subtle. This behavioral variation can come from the system drifting or the respiratory motion change the chest volume or the cardiac pulsation, and can also come from bulk motion. So behavioral variation is not a big problem for like techniques such as the gradient echo with a short T, but it can be a problem for all the long T equation like the T2 star and the QSM. Conventional way to correct for motion and delta B0 is that people may periodically insert some low resolution full volume navigator to calculate the motion and delta B0. And the drawback is that those additional equipment takes probably half to 1 second additional. And that means the time resolution of the motion and delta B0 estimation cannot be too high because the actual cost of the time will be too large. And recent years, people have also been largely developed this Scout image plus tailored navigator for motion estimation. What they do is that they acquire a Scout image ahead of time, and they only acquire the tailored navigator every few milliseconds in the actual accreditation, and they perform optimization to estimate the motion parameters against of the navigator against the Scout image. But the challenge is that for this method, it's always really hard to get the motion and the delta B0 estimation altogether because this is also a very ill-posed problem. So what we proposed here, which we just submitted an abstract to this year's SSMRM, is this Scout-based multi-echo navigator, SMINA. So in this framework, we acquire a multi-echo Scout image with EPI accreditation, which can be done with only 3 seconds. And in the actual accreditation, before each EPTI shot, we add a very short navigator, which is a multi-echo navigator with 6 echoes at only 3.5 milliseconds. And every 4 navigator at different case-based coverage will provide an estimation of the motion and delta B0 information through this optimization equation, which means we can do motion and delta B0 tracking every 200 milliseconds. That is a very high time resolution. I briefly show the results where we apply this SMINA motion and B0 tracking on not only just the EPTI, but also combined with the multi-echo GRE. In terms of the estimation, we can see SMINA compared to the ground truth, those low resolution whole volume navigator, it actually shows a pretty close estimation with very low errors for both the rotation translation as well as the delta B0. And for the correction, we can see if there's severe motion in EPTI, the image quality actually is highly reduced. If we only do the motion correction with those low resolution navigator, sometimes you can get even worse results when you're not capturing the fan motion and delta B0 profile. With this minor estimation at high time resolution, we can have much better correction. And we can see with the joint motion and delta B0 correction, we can get the best image quality, especially for T2 star and QSM. And the same thing can be observed for the multi-echo GRE, where SMINA can be flexibly applied for different structure. And the same thing, the SMINA estimation, the SMINA high resolution estimation of motion delta B0 provide favorable results, while the joint correction of motion and delta B0 provide the best results. And we apply this joint robust spherical EPTI pipeline on some very challenging patient cohort as infant study. And we can see with a spherical EPTI with a very short scan time at 45 seconds, it provides very nice T2 star weighted image, T2 star map, and QSM compared to the conventional multi-echo GRE, where it's about 6 times longer and definitely not robust because of the like the unwanted motion from the infant study. Yeah, that's basically conclude on my technical presentation. And at the next step, EPTI is very flexible technique. It can be used for like a large patient population, and there's lots of ongoing and future works, including the motion and B0 tracking for better outcomes, some potential separation about the margin and iron, and potentially we can apply this very robust, very efficient spherical PTI technique for a lot of multiparametric study, like the T1, T2, T2 star, the fusion, and also like probably single shot functional MRI study. So as a true conclusion of my presentation today, I will just briefly look out into the future of MRI by taking all the advances people have been doing over the years together. I'm pretty sure like at not so far future, MRI will become a true push button style where it will just require very fast working session with a short scan, and all the information can be captured during the continuous acquisition with efficient encoding and high quality smart decoding. And those rich information will be automatically diagnosed and analyzed for the patient outcome, for the longitudinal follow-up, and for the accessibility to everyone. And yeah, that's all. I want to thank all my colleagues for my PhD and my postdoc group, and thank you all for giving me the chance to present my work here. And I'm happy to discuss for any details of the work. Thank you so much.
Thank you very much for a really excellent talk. So there were some questions posted in the chat. So the first one from Dr. Sinha, he was asking about the entire scan time for the DCE acquisition, how many 3D partitions, and the steady state question. Is the data acquired in steady state? And can you add a saturation slab at the beginning of the acquisition?
I see. So yeah, for the entire scan time, based on different applications, the scan time usually varies from 5 to 10 minutes. So that's like the entire scan. So including the pre-contrast part, the injection, as well as the post-contrast. And this scan time is actually flexible. So 5 to 10 minutes is usually because we want to create the entire, like the dynamic curves during the contrast injection. And in terms of number of partitions, like for also like that varies from application to application. For our liver application, it included 60 to 120 slices covering the entire abdomen. And for the breast application, I think it's included about 200 slices, which is matching the clinical coverage and very thin slice at 1 millimeter. And yeah, in terms of the sequence structure, currently we are not doing studies like we like perform this periodic saturation recovery to allow for the like the dynamic T1 mapping. But actually, I'm pretty sure like the dynamic T1 mapping part is not you have to do. You can probably use a more like the steady state sequence, like no saturation recovery, but just the steady state GRE to get the information you want.
I guess I was asking, sorry, Claude, if I could just, for the total scan time in the sense of, suppose I was to apply to a cardiac scan. Here you're just adding on whatever number of partitions you want to the DCE, and you could continue it, theoretically ad infinitum. But in a cardiac scan, you would be limited in terms of, the diastolic phase or something like that. And in that sense, would be the each of your acquisition times. And the steady state question I asked was essentially to see if you could suppress blood, which might flow into the anatomy of the breast, for example.
Yeah, actually, for the suppression of the blood and the surrounding tissue, that's something totally doable. Like you can either use saturation recovery, or we can replace with inversion recovery to have a much better separation between the blood and the tissue. And yeah, for cardiac imaging, I would totally agree. It's much more challenging because of the appearance of the cardiac motion.
Right.
Our group actually also doing something similar to the multitasking DC, but like more like the multitasking perfusion on cardiac. I think at that time they were more like doing a few slices, like not a huge cover, but more like probably a few slices covering the different section of the heart. But that was also about like just within quite short scan time, probably less than 5 minutes to get all the information. I think they are probably doing 1 minute scan with a few slices to get the contrast in the heart.
Okay. Thanks.
Yeah.
Great. Thank you. Claude, did you want to ask your question? And then we'll get back to the chat in a minute. Go ahead, Claude.
Oh, well, can you guys hear me?
Yes.
Yes.
Yeah. First of all, I just wanted to express my gratitude to Nan for giving this talk, and and to Tom for organizing this. So Nan, as you remember, we met a few months ago in July, and it's just so wonderful to see that things are progressing and that now you're giving this wonderful talk. So thank you so much, for presenting to us. And I want to, thank Tom and Christine and Conan for their work and actually, progressing to where we are now. Now, I have a lot of specific questions about your techniques related to liver, and I don't want to overwhelm everyone with all of my detailed questions. So maybe you and I can chat a little bit offline, but maybe just a couple of questions. You probably mentioned this, but I forgot. When you said there's high spatial resolution for your multitask MRI in the abdomen, what is the actual resolution? What's the matrix in plane, and what's the slice thickness?
Yeah, so for that's like kind of a varied for different application. And for the pancreatic cancer study with the multitasking DCE, the in-plane resolution is 1.2 covering the entire abdomen, and the slice thickness 6, and that in slice thickness 6 with 60 slices covering the whole abdomen. And we also have like the T1, T2 star proton density, fat fraction quantification of the liver. And for that project, our resolution is 1.5 millimeter in plane and 5 millimeter slice thickness, and that also including about 40 to 50 slices covering the whole abdomen.
Is there flexibility in the spatial resolution? So can you trade spatial resolution for either higher or slower temporal resolution?
I mean, for DC MRI, actually, I have to say the trade-off is not between the spatial resolution and the temporal resolution anymore because it's already decomposed into the different factor matrices. But the trade-off is mainly from the total scan time. So for example, if you want to keep both a really fine temporal resolution as well as even higher spatial resolution, you probably need to use a longer scan to get a better estimation of your factor matrices.
Okay.
And for like the liver quantifications are quite flexible. I know sometimes for those like the chronic liver diseases, people may not yielding too high spatial resolution. And in such case, if you want to even lower the resolution, you can probably get like even shorter scan. Like for now, we do like 5 minutes free breathing scan, but let's say if you have the spatial resolution, the scan time can be reduced to like probably 1 to 2 minutes.
Great. Thank you so much. I'll let other people ask their questions. Really appreciate it. Thank you.
Yeah, thank you very much.
Right. Thanks a lot. So moving through the chat questions, there was a question about the post-processing. How long did it take? And I think that was related to the DCE part of the talk.
Awesome. So yeah, post-processing for DCE work, the reconstruction of the image usually takes about 4 hours because for our DCE work at that time we're using Cartesian, so the time is not crazy, but also takes like about 3 to 4 hours for the recount. And for the post-processing, that's actually quite fast. After we got all the image recount, then probably each slice will only take definitely less than 1 minute to get all the like the dynamic T1 mapping and the DCE parameters out of that. So yeah, the process is mainly the main part still the reconstruction, which takes about 3 to 4 hours.
Great, thank you.
But I know like yeah, but like because this time is like based on my PhD, which is about like 4 years ago. I know like over this 4 years, there's lots of like the even powerful utility of the like the GPU and stuff. So I believe like currently like if we dedicate on that part, we can definitely make the recount time even shorter.
Great, thank you. And there was another question from Dr. Mal about he said excellent work and presentation. He said the image recon framework is similar for the liver and brain imaging work. Can you please discuss the similarities and differences between the two works?
Yeah, that's a really good question. And yeah, for all the reconstruction, I think the key point we used here is this one I have been talking a lot about in my presentation called the low rank subspace framework. So I think that has been a kind of one of the mainstream people do to reduce the scan time and to exploit this high correlation along the image dynamics, especially for lots of the spatial temporal imaging. The entire like the general framework is quite straightforward, but it's also quite different for different application. For example, in body imaging, like the one major challenge is to resolve the physiological motion. So physiological motion is something you have to have some real-time record to make sure you know each of your key space belongs to the right motion states. Otherwise, if you got that mixed, you will probably have a worse quality of your final refraction. So for all the body imaging, I think we kind of spend a lot of time on designing our the acquisition of the temporal subspaces, like more like a periodic acquisition of the center key space line, and do some like the facial expression about the motion to make sure we get the correct motion states. Like that's not only challenge for respiratory, but also challenge for heart. So that's, I think, will be the biggest challenge for the study of the motion. The study of the body because of the motion. And for the neuroimaging, I would say because we are really pursuing like very short scan time and high spatial resolution, the major challenge lies in such undersampling rate. Any imperfections, like some very small errors in the bidder estimation or some like the eddy current induced phase errors can give you artifacts. So I think for brain, what we did is that we really characterize all this like the imperfections and trying to include that in our model to make sure we can reach a higher acceleration and better image quality in the same time. I think that's always the trade-off between your acceleration and your image quality. And if you want to reach them together, you probably need always need better calculation of like those imperfections in your model to make your model better, to make your image quality better.
Great, thank you. So maybe I'll ask a question. So, obviously the low rank approach is becoming more popular. In your work, so in your two areas that you've looked at, have you seen any areas or have run into places where the low rank approximation, it doesn't take into account it's sort of making a pretty big assumption. And so have you seen any cases where that assumption falls apart?
That's actually a really good question. Totally depends on your application. For example, for our EPT application in brain, where we are currently target on the T2 star mapping and QRT mapping, like this low rank subspace framework has been worked out pretty nice. And recently we had also like in conversation with like other professors from like the psychology and neuroscience, and some people really care about some of the, for example, the component with a really short T2 star and decay fast at the beginning. And for those information, for example, for now, it's really hard to capture by our current low rank model. So to capture like those information that has been filled out by your current low rank model, you may need to have for example, better design of the model, a better design of the temporal subspaces, or probably increase in your rank of the subspaces you want to use, and probably result like a longer scan time based on how many more information you want to include in your model. Yeah, I would say like this low rank subspace model is definitely a really, really powerful model, but it also requires a very careful characterization to make sure you're really modeling the information you're interested in. And for DCE, the same thing, like DCE, because the enhancement can be really sharp. And we do notice like, let me restart sharing my DCE slides. Yeah, and yeah, we do notice like, especially for the peak in the blood, sometimes it might be a little bit smooth out because this low rank model is tends to like reduce the noise, but in the meantime can also reduce some like really sharp information from your actual data. Yeah. So can you see my screen again?
Yeah, we can see it. Thank you.
Yeah, awesome. Yeah. So yeah, for our DC, we do know sometimes, for example, the peak of the blood might be actually slightly underestimated compared to other results if you're only trying to target the peak of the blood. So that's always the trade-off between your like the model you're undersampling and the true fidelity you're sticking to your data. But I would say that for now, it seems like not affecting too much in the estimation of our model, the DCE, the microvascular properties, those estimation. But yeah, that's something I would have to keep in mind that if you regularize your model too much, then you're probably also losing information.
I guess maybe a follow-up question is to what extent, like for example, in functional brain imaging, one thing that we have to worry about is like spatial temporal phenomenon where space and time are linked. So doing a space-time decomposition is not always inaccurate. For example, a traveling wave is space and time are closely linked, and so doing a low rank tensor approximation would be. So do you see that in any of your DCA data where maybe space and time are linked, and so this approximation is creating errors?
Yeah, I would say that's a really good question. And for now, like for DCE, like for especially the body DCE, from what we have been observed, this has been not too much trouble because I guess for body DCE, it's not like too much circle back of the signal. So as long as you get this entire trend with a phantom resolution, that's okay. But I totally agree for functional MRI because like the contrast the people are targeting is like much subtle. So like that can be actually a more challenging case. We used to like try a little bit on like trying to use the low-rank model to capture the like the dynamics over all the like the functional phases, and that actually gives us actually something like you actually notice higher correlation of different regions because you're using a low-rank model, so you're actually like filter out the noise and exaggerate the correlation, which is probably not true. So yeah, I totally agree. For functional MRI, people may definitely need to be more careful. And one way is that probably don't use the low rankedness along the functional activation dimension, but probably more use the low rankedness in the like sort of in the perpendicular way to your acquisition, like along the functional activation dimension, probably not use any low rank assumption, but in your acquisition, like for example, along your different echoes, things like that, you can probably use a little bit of the low rank estimation to accelerate your entire scan, but in the meantime, keep the like all the subtle contrast changes along your functional activation that dimension.
Great, thank you. And for the DCE work, so in the sort of, I know when you did it was for your PhD, and since then the group has continued to work on it. What are they finding to be sort of the challenges in getting it adopted clinically?
So I would say clinically for DCE and also for the severe PT I was getting right now, still like the recount time. The 3 to 4 hours recount time already kind of make our images not able to provide the real-time feedback for the clinicians. So that's like the biggest challenge. And the second challenge would be like for now, like the DCE actually, this multitasking DCE provide probably too much information, and which is currently for clinicians or radiologists, they probably don't need them, or they probably not sure like how we can efficiently use them. So I think that's what totally requires some like long-term collaboration between the researchers and the clinicians to really figure out how to efficiently use those like the richer information to probably get better diagnosis or like other useful aspects for patients.
Great.
But yeah, currently I know the Bell's group, some students have been kind of trying to utilize also deep learning in the analysis of the data. I think that can be a good thing because I think deep learning can definitely plays a like more and more important role in lots of different aspects of the MRI, and it can probably help at the first line information extraction. So that can simplify the work for radiologists to get the true information later.
Great. Let me see. I don't see any questions. I'm going to keep asking questions till someone else asks a question, so that's okay. So,
sure.
So for the deep learning for the spherical PTI, you showed better image quality. What do you think are the main? What do you think the deep learning network is doing? Like what is the main? Like if you could sort of look under the hood of the deep learning network, how is it achieving its gains?
So yeah, are you seeing the deep learning slides?
Yes.
Yeah. So yeah. So currently what we utilize in our work is like the physics-informed neural network. So I think it's not I feel like this is not as strong as some of the other like the direct end-to-end neural network to directly get your result from the kit space. But this neural network kind of it actually performs more like a regularization, but with some prior knowledge. One like the potential advantage for neural network is that because it still utilizes your entire recount model and it's only like performed as a regularization. So I've been looking through studies, like even for like if you have like limited number of training data, you can still probably get some like the true to data outcome rather than get a lot of hallucinations. But on the other side, like a neural network with like very like currently we train that on 10 subjects, which is definitely not enough for like the large scale robust model. So that will be something like we'll keep doing in the future, like to acquire more data. But yeah, currently given the limited training data we have, the neural network is more like performing an some actual regularization based on the prior knowledge of the similarity of the brain it has been seeing. So like more training data will definitely improve its performance as well as reduce its like the hallucination ratios. But it's in terms of the smaller data set, I think the neural network is definitely much better than those like the more end-to-end like the deep learning network.
Did you have a question, Katie?
Yeah, I was gonna ask. I don't know if you can see, but
You can come over here and ask.
all right.
We're going to have another question from Katie, so he's going to come over here.
Hey.
I just don't want to unplug this.
Great talk, by the way. I was just wondering what's the recon time for the CPTI with all of your added stuff that you implemented.
So for APTI, currently what we can do is for 1 millimeter data, because we are still using like more like the Cartesian sampling, and it's and the readout direction is in the head foot direction. So we first perform an inverse Fourier transform in this direction, and then we do the like all these fancy recon steps like slice by slice.
Mm-hmm.
So for that case, like for the 1 millimeter data, each slice takes about 30 to 40 seconds on GPU. And for 0.75 millimeter data, each slice takes about 1 minute. So that's just like for the 1 millimeter data, we have 240 slices, which takes probably about 2 to 3 hours. And for 0.75 millimeter data, we have like about 300 slices, which can take about 5 hours. But our group also recently have kind of developed a better way to incorporate, and the major time consuming part is because we have to include it, like we separated the B0 estimation and the final recount, so we have to include this B0.
Yeah.
Sorry. Yeah, have to include that B0 term, like as a spatial temporal term, which is actually quite large matrix. Like this term, like the B0 induced fit is actually a spatial temporal term, and that's a large matrix, and that's actually it's a most time consuming part in the entire recount loop. So like currently our group is already working on another method to kind of doing also a decomposition of this B0 induced term to kind of smartly decompose that into fewer representations. And that can already significantly reduce the, I think the recount time for example, for the 1 millimeter, the whole volume to about definitely within half an hour and can be even faster. So yeah, I think there's a method, but currently it still takes about like 2 to 3 hours for a robust outcome, but there's definitely room to further reduce the recount time by smartly factorize different part in the model.
Awesome, yeah, and also I know from the EPTI, like the MGH group, they proposed they did a shot to shot B0 update as well. Are you also incorporating that? So that's all, yeah, integrated into.
For that part, I would say it's definitely more. From my observation, I think the shot to shot B0 variation will be bigger challenge for all the 2D study, like for the functional study or like all the like the diffusion study with a 2D equation, because in 2D you eventually have fewer shots, so all the imperfections between the shots will give you probably a larger error. For 3D, it's definitely much better because 3D you have more shots, you have this distribution over entire key space. Those errors actually become more incoherent, so you're actually better to that. But yeah, in the meantime, like for the last part at present, like we're also trying to do a motion and this delta B0, which is can be sort of like a shot-to-shot B0 tracking, because the shot-to-shot B0 variations also mainly coming from like the respiratory or cardiac pulsation, and that's also the target of our last part of the work, like the dynamic motion and B0 tracking at a high temperature motion to prep for such variation over time. And it did show like if you do correct for both stuff, although in this work, like those B0 differences mainly come from the motion, but like all other sorts of the B0 variation, if you do correct them, you can also see improved image quality.
Awesome. Yeah, sounds great. Thank you again.
Yeah, thank you very much for the question.
And do you mind going over the eddy current correction again? I didn't quite catch what you were doing there.
Sure. I believe it's here. Cool. And this is what we did. So currently what we did that is that we have to acquire this low resolution multi-echo calibration data ahead of time that provide us with the sensitivity map, the initial behavioral guides, and now we also estimate phase error between odd even echoes. So the phase error is like a sort of a slightly higher order phase error. This is the residual phase error after you even got this gradient delay correction. And then we incorporate this phase error, like this is our original recon model. Then we incorporate the phase error into our recon model.
Okay, great. Okay, thank you.
So we did the same thing for EPI, which is also works quite nice. And we I also have another work called field correcting guapa that can be a more general methods to correct those like the high order phase for API.
Okay, great.
Yeah, I can share some of that's like very recent work to you. Like it's also like just to have a two SM abstract, but I think the idea is quite straightforward.
Sure. Okay. Wonderful. Okay, I'm not seeing any more questions, so I think thank you again for a really wonderful presentation and taking all our questions, and congratulations on all the really wonderful work you've done.
Yeah, thank you so much for the chance to present here and I appreciate all the questions. I think they're like super great questions, and I think that's some actually the really like the main points we always like keep in mind and probably try to overcome in the future. And I really enjoy the discussion of this, and I really appreciate the chance to present this work here. And hopefully we can have a more chance to discuss in the future and to like to get like more ideas for like how we can pursue for future directions.
Great. Yes, we look forward to that. Okay. Thank you very much. Okay. Thank you,
Yes.
everyone.
Thank you. Thank you very much. Thanks,
Okay.
everyone.
Bye.
Bye.
Should I end it?